All right. Okay, we are started, and then let me see if Kim, you there? Dr. Landry?
Hey, good morning.
Good morning. I think Paul may want you to tell the story on Maine Eagles today. Did he call you on that?
Oh, yeah, he did, and he actually sent me the link.
All right. So that what I think people are going to be pleasantly surprised by that story. Oh, I think we lost Kim.
Hold on, let me answer this call. I'll be right back.
Oh yeah. Go ahead. Okay. As far as hey, there's Dr. Lee. Hey, Dr. Lee. Let me make sure that I ultimately get the codes for today. I'll put those in the chat. But let's go ahead and get started because we are at the top of the hour, and I really want to hear everything that Tommaso has to say here. So, welcome everybody to the post July 4th edition of the Florida EMS webinar, and we are recording today, so just keep that in mind. Today we are being joined by Tommaso, and your last name is hard for me to pronounce. Scquizzato, maybe.
Perfect.
Who wrote a great editorial in Resuscitation Plus on ECMO, CPR, ECPR, and the title was ECPR, Now a Standard of Care, ? And he is a social media editor of Resuscitation and Resuscitation Plus. He joins us from Milano. He's a great writer and a great contributor to the field. And when I found him on Twitter and I sent him a message, he right away responded. And so people like that who have kind of EMS in their blood, we really appreciate. So without any further ado, Tommaso, thanks for joining us, and take it away.
Thank you, Peter, for the invitation. Thanks to everyone who is listening and Florida EMS. So extracorporeal CPR. And when I wrote this editorial, Now a Standard of Care, I received many positive and many negative comments, because saying that something like extracorporeal CPR is a standard of care is very complex, because there is inequitable access of ECMO. There is a very hard complex procedure that are currently not performed everywhere, and so saying this is sometimes very hard. And actually, I'm speaking from this hospital. It is my hospital in Milan. It's a research hospital. And here, ECMO and ECPR is currently a standard of care. We perform ECPR for refractory out-of-hospital cardiac patient 1 time per week. And this started in 2013. So we perform more than 300 ECPR cases in this period, and we usually perform 100 ECMO per year. So in our hospital, in our EMS system, every patient who has the criteria for ECPR get cannulated. So in our reality, ECPR is now a standard of care. And let's start from a very rapid introduction to remember the numbers of the problem. Cardiac arrest is a huge problem. Many people die every day and every year in Europe and the United States and all over the world. And the number, you know perfectly what are the numbers. And often 3 out of 10 achieve a return of spontaneous circulation. Only between 2 and 15% survive to hospital discharge. And surviving cardiac arrest, as you know, is a race against the clock. You know perfectly because you work in EMS, and so every second count when treating these patients. And we know that some factors are protective, and so we know that early bystander intervention, CPR, AD, can be protective towards some delays. And so this is a key point to remember for all this presentation. And I'll ask you, how would you like to survive a cardiac arrest in 2022? We have different options, maybe mainly 2 options: by chance, but we don't like this option, I think, and by system. And I think that we have to work on the system. And the starting point to think of a system for cardiac arrest, system of care, is to remember the chain of survival. I don't want to spend many words on this because you perfectly know what is the chain of survival. But I would like to remember that some links are more important than others. So early recognition and early CPR are the main links of the chain of survival. These links are really improving survival. And the integration with the community is another key point for improving survival. Also, when we are talking with ECMO and these advanced technologies, we must not forget this basic aspect of cardiac arrest care. And if we talk about advanced life support, also in this case, we have many question marks because a lot of interventions were tested in randomized trial, coronary angiography, intraosseous access, mechanical devices, intubation, drugs, and more recently, the highly debated temperature control after cardiac arrest. And all these interventions failed to demonstrate convincing effect on survival and neurological outcomes. Many of these interventions actually failed to demonstrate benefits in terms of survival or neurological outcome. And so this translates that many times we are able to save the heart, but we achieve ROSC, but we can't save the brain. And these are really key issue for saving these patients. And this New England Journal paper published a couple of years ago, remember that the risk of death or the risk of being discharged with a brain damage or admitted to the nursing home is higher when we do not have bystander resuscitation and lower when we receive bystander intervention. And this is another key point to remember. Now let's move to extracorporeal CPR. So ECMO applies during cardiac arrest. And let's discuss some of the latest advanced intervention. One of the latest advanced interventions landed in the field of cardiac arrest. Very rapidly, what is ECPR? This is ECMO. It's a combination of a blood pump and an oxygenator. We deliver oxygen, we remove CO2, and we can also manage temperature. And we can support both the pulmonary aspects and also the cardiac and the pulmonary combined. So we have the VV or the VA configuration. ECPR is the use of VA ECMO in refractory cardiac arrest patients. So the cannulation is performed while CPR is still ongoing. And this is done under considerable time pressure, as you can imagine. And usually it is provided as a bundle of care. So this is not a standalone application intervention, ECPR. And the rationale, of course, as you know, is the ECMO can provide a higher cardiac output compared to conventional CPR, and can also easily control temperature and can preserve the brain while awaiting for ROSC. And so we can perform treatment of underlying causes and waiting for cardiac recovery. And this is all summarized in the concept of a bridge. So the fundamental premise of treating patients with cardiac arrest or also cardiogenic shock is that ECMO is a bridge to recovery, a bridge to a more durable bridge, the bridge to definitive treatment or to a decision. So we can support ECMO temporize circulatory support and can provide supportive treatment to the patient. So we can wait to the recovery of the patient to decide if there is something recoverable. For example, we can exclude the catastrophic brain or cardiac conditions, or we can bridge the patient to other mechanical circulatory support devices, for example, percutaneous left ventricular support or long-term VAD devices, or also even heart transplantation. And then we move to the comparison of ECPR. So this novel, recently introduced intervention in the field of cardiac arrest to the conventional CPR that we perform for many years, and so this is a very hot topic. Actually, I should have updated these slides because now there are more than 170 observational studies published available on PubMed, and so this is a very huge topic. Many of these studies are observational and describe single-center experience with a CPR. And these studies reported improved survival and neurological outcomes compared with conventional CPR. Systematic reviews and meta-analysis of these observational studies also suggested the potential benefits of CPR. However, we have to remember that we are talking about observational studies, and so the risk of bias is very high, and randomized trials were needed. And so we moved to the recent two randomized studies, a Lancet in 2020 and a JAMA in 2022, the ARES trial and the Prague OCA study. These two studies were really needed and important to understand the effect of a CPR in patients with cardiac arrest. The first one performed in the US, and so you really know well, is a single-center randomized trial, enrolled the patient only with refractory ventricular fibrillation in the out-of-hospital setting, and a small study, 30 patients, in a paramedic-based EMS system. And the intervention performed was in this sequence: out-of-hospital cardiac arrest, dispatcher-assisted CPR, and early transport with ongoing mechanical CPR for every patient enrolled in the study. And only at hospital arrival, the patients were randomized to receive a continued standard ILS or moving to ECMO ECPR. And so this is a very different studies compared to the European one, but we'll talk in a while. And the US study demonstrated high survival with ECMO. If patient treated with ECMO had 33% survival compared to the 7% of survival in the standard resuscitation group. And this is a huge difference. So this study tested the concept is applying ECMO is effective in patients with cardiac arrest. So the direction effect is clear. We have possibly a very huge benefit. This is the Kaplan-Meier survival, showing a very clear difference between the two groups. In this trial, patients did not cross over between the two groups. So patients allocated to the ECMO group received ECMO. Patients who were enrolled to the standard ILS group received standard ILS group, standard ILS resuscitation in the emergency department. And now we move to the Europe. So single center RCT. Now enrolling also non-shockable rhythm. Very large study, almost 300 patients, and in a physician-staffed EMS system. Quite different from the US study because the randomization were performed in the out-of-hospital setting. So patients stayed in the out-of-hospital setting and continued ALS on site, or were immediately transported with ongoing mechanical CPR. So patients without ROSC were declared dead on the out-of-hospital setting. And patients arriving to the hospital because randomized to receive ECMO were treated with a CPR. And yes, this is what I currently said. And in this study, crossover was permitted. So patients can be crossover between the two groups, and this is the chart of the crossing over. So we see that 11 patients that were allocated to standard strategy crossed over to the invasive strategy, and 5 survived. And 9 patients instead allocated to the invasive strategy crossed over to the standard strategy, and no one survived. Overall, 64% of patients allocated to the invasive strategy received ECMO. This means that some of patients actually achieved ROSC during the ambulance transport or after arrival to the hospital. And this is a very important information that can be seen from this study. 6% of patients were actually randomized of every cardiac arrest occurring in Prague. So this means that we are talking about a very selective population of patients. If you think in your EMS system, the patients that actually have the criteria to receive ECMO is very, very low. We are referring to a 6% of patients with out-of-hospital cardiac arrest. So a very small population of patients, very, very small. And also in this study, patient had a sign of benefit, but the statistical significance was not achieved in the primary outcome. So the study was interrupted early, and for a benefit in the secondary outcome. You can see no difference in the primary outcome, but a difference in the secondary outcome. So I think that we can say that the direction effect can be clear. We are not doing harm. There is possible some effects, and the secondary outcome indicates us that the survival can be improved. The short-term survival can be improved with ECMO in these patients. And this is the Kaplan-Meier survival curve. And let's discuss a little bit of what happens when we put together some studies. We decide to perform a very rapid systematic review and meta-analysis of randomized and propensity score match studies to reduce the risk of bias. And we found that the direction of effect was really similar to what demonstrated by randomized studies. And again, there is no signal of harm. There is no signal of increasing the number of patients surviving with neurological deficits, because you perform cannulation after also 1 hour of cardiac arrest. And so the risk of increasing number of patients surviving with neurological deficit is possible. You can start almost every time the heart with ECMO, but the brain can be irreversible death. But this is not the case. There is no signal of increase of survivors with brain damage. And so overall evidence are in favor of treating ECPR with ECPR patients with refractory cardiac arrest. But now let's move to a really important concept, because no magic bullets exist in cardiac arrest care. Every time we have to think that ECPR is a part of a bundle of treatment that begin in the pre-hospital setting, continue during transport, and conclude at in-hospital arrival. And to achieve high rates of survival in an ECPR program, it is important to accurately select patients, so consider eligibility of patients, perform effective, high quality, high standard pre-hospital resuscitation that begin with dispatcher-assisted CPR, early bystander CPR and defibrillation, and rapid identification of candidates by EMS provider, and prepare the patient for rapid transport. And during transport, you have to coordinate with the receiving ECMO center to continue high performance CPR and try to work in a network that collaborate with ECMO centers. And after in-hospital arrival, it is important to reduce the time, because one of the most difficult aspect of ECPR is actually logistics. It is not a clinical problem. ECMO centers are really, really good in doing cannulation of patients, and most of the problem arise from logistics. And so coordinated different actors from the pre-hospital setting to the in-hospital arrival, it is really a huge issue. And then after arriving in the ICU, rigorous post-resuscitation care, and again considering a comprehensive approach to these patients. So from the management of brain injury to the management of cardiac recovery, and also when nothing more can be done, to consider organ donation. And our goal should be always to buy to buy time, so reduce no-flow time. Remember that no-flow time is our enemy, and brain injury occurs very rapidly after cardiac arrest. So work to reduce timing. So reduce no-flow with bystanders, reduce low flow with quick, rapid EMS response, and early CPR is always the main and the most effective way to do this. And this is a very schematic representation of actually how the time is when you treat this patient. It is impressive how time flies when we treat those patients. No flow, bystander CPR, ambulance arrival that start BLS, then advance to the life support. And it is important to declare that the cardiac arrest is refractory. And also there is a lot of confusion what is a refractory cardiac arrest. And it's important to decide rapidly to move to the in-hospital setting to continue resuscitation. And to support this statement, I would like to show bystander CPR in Europe. Actually, half of cases received bystander CPR in Europe, but in the Prague region, where the Prague study was conducted, 83% is the bystander CPR rate. And initially, before initiating a CPR program, is of paramount importance to focus on bystander CPR intervention. And so community initiative and awareness. So without bystander CPR or AD, any further advanced intervention will have only little or no effect on outcome. You can put on ECMO, but this patient already already brain dead. If after 10 minutes of resuscitation, after 10 minutes of cardiac arrest, nobody initiated CPR, use an AD. So bystander CPR is of paramount importance. In Italy, in Milan, it is very difficult to reach the patient with a first ambulance before 10 minutes. So without bystander CPR, the patient we already said would not be possible, because without bystander CPR, the patient died. So another data from these two trials, you can see that these two trials had very high bystander CPR rates. And so this is very important when someone thinks, oh, I would like to start a CPR program. We have to watch what is the bystander CPR rate in your community, and try to work and improve the first aspect of the chain of survival. And these recent studies published, observational studies published in Resuscitation Plus from a group in Denmark, show that the rate of survival with favorable neurological outcome was higher than 20%, also for patients with low flow times higher than 75 minutes. And in this study, bystander CPR was more than 90%. And this is a clear signal of how protective is bystander CPR, how bystander CPR can prolong the time of advanced intervention that can be performed in those patients. So bystander CPR is a key point for every advanced intervention. And when I talk about ECPR, I'd like to make everyone think that the E of ECPR means two different things: early CPR and extracorporeal CPR. This is a key concept. Without the first E, early, extracorporeal CPR is very hard to work. Patient arrive to the hospital, you cannulate the ECMO, but you immediately realize that without bystander intervention and prolonged no flow time more than 10 minutes, often these patients are completely brain dead. And this is a very huge issue, both for families, both for providers, both for the community. And another key point is to create cardiac arrest center, like trauma center, stroke center, STEMI centers. Also, cardiac arrest centers should be created in the future in every region, because these patients require a high complexity, high intensity of care. They require a complex post-resuscitation care. They require experienced provider, temperature control, advanced ventilatory and circulatory support, ECMO, left ventricular support devices. Cardiogenic shock is often present in those patients, and a comprehensive care can be provided in a cardiac arrest center. Pre-hospital CPR is a very complex topic. I would not like to to very rapidly talk about this topic because it requires a lot of discussion, but this should be considered. The rationale of hospital ECPR is to reduce low flow time, but it's very complex to do ECMO outside the hospital. So EMS systems doing this are very, very, very good in this, and they must be congratulated for the effort because they're really complex doing this. And the future, the future is a large multi-center randomized trial to confirm those findings and provide firm recommendation also in different settings and different population of patients. And we await these results. Many studies are currently enrolling patients, both in hospital and out of hospital cannulation. And we still have to understand which patient might benefit the most, and in hospital versus out of hospital, the logistical aspect, and how we can generalize those findings to other setting, other reality with different system of care. Take home message, I think that from a presentation like this, that ECPR requires a substantial investment of resources. It is not simple to initiate ECMO. If an hospital never provided ECMO, starting with ECPR is really complex, in my opinion. So better create ECPR center in already established ECMO center that provide ECMO, for example, for post-cardiac surgery, cardiogenic shock, or VV ECMO for respiratory distress syndrome or other condition. And ECPR randomized trial and observational studies show that it's feasible. There's no doubt on the feasibility of ECPR in a trained system, and can improve outcome in high-performance system. So with high-performance system, I mean system that optimize the first link of the chain of survival. So start in a system, 10% of bystander CPR is maybe without any potential benefit. But if you start ECPR in a system with 67, 80, 90% bystander CPR rate, you give the possibility to these 6% of patients that do not achieve ROSC in the out-of-hospital setting to benefit from this intervention. And the results are those shown in the randomized trial. So bystander CPR and defibrillation are key for survival, and selecting patients is also key. I leave you with a summary of our meta-analysis so you can remember all the key points. And if you have any question, you can follow me on Twitter, you can write me an email, and I'm very happy to discuss and chat with you all. Thank you for your attention.
Wow, Tommaso, that was an amazing review. It's just really nice to see all that data in one place, and really all the important really subtleties of the data. I did want to bring in Dr. Pepe and then Dr. Scquizzato for a couple of comments. Go, Dr. Pepe, unmute yourself.
Okay, thanks. Buonasera, Tommaso. Grazie mille.
Wow.
What hospital do you work out of? I couldn't catch that. I didn't see that.
Yeah, in northern Italy, Milan, San Raffaele Hospital.
Ah, yeah, San Raffaele. Yeah, okay, good. Okay, fantastic. We work closely with Roberto Fumagalli, we'll meet about that sometime. The one comment I think I want to reiterate, you said this already, but that our one is that it was a select population, and an appropriate choice is probably a good idea. And in the study, for example, the ARREST study, because I helped them with writing to the editor at the Lancet to get the paper accepted there. One thing we noted was that the average age was actually 55. So you could argue that it's a salvageable age of people who could go back to work, et cetera, and all that, but it's the selection of the group. The other thing I think that is important is that they actually stopped that study early because it showed benefit, as you kind of said in other studies as well. They had to stop early because it was already showing benefit, so there's no reason to continue the study further. And the idea about bridging to getting to even in the in-hospital setting is a good idea. We're working on that here locally. Plus, just as an FYI to you, we are setting up statewide resuscitation centers here in Florida, and that's why there's a lot of interest here. So I just wanted to let you know that, and be glad to. We could talk offline sometime, and I can help you with various things. So, and with that, I'm going to chain my survival over to the other side. Okay, Peter.
I'll make sure to connect you and Tommaso, Dr. Pepe. But let me bring in either Carrie Batista or Ken Shepke. Ken, you want to go first and talk about what you and Carrie are working on at that level?
Yeah, absolutely. Fantastic presentation. Thank you so much for that. It's great information. It's something certainly we've been interested in a long time. And I know you're comparing it to conventional CPR, but one of the things that our group has actually been working on is also neuroprotective CPR, which is also more colloquially known as head-up CPR, which I think drastically improves.
I'm on another call right now, so I'm going to put me on mute.
Drastically improves cerebral blood flow. Paul, you're not on mute. So
sorry.
I wonder if that could make your results even better as doing that type of CPR as a bridge to extracorporeal. And I do think obviously the European system is a little different. You have physicians in the field. We've got paramedics. I do though think that eventually at some point paramedics will be able to learn this skill. We just have to train a certain number of them. It won't be everyone. Maybe like what our EMS captains or some of our specialized providers. But I do think this is a way to go. I think your results are showing that there's definitely a population that we can do better for, and absolutely wholeheartedly believe in cardiac arrest centers, or we're calling resuscitation centers. Every single disease we've done this with, we resulted in lower mortality, lower morbidity when you have a specialized regional referral center for high acuity, low frequency events like this one. So I definitely believe in that. And I know Dr. Patrice has been working on that for us.
Awesome, Ken. Thank you for that. Carrie, did you want to jump in, or Dr. Daya? Obviously, one of the leaders of the ROCK trial. Any comments from you guys before we switch over?
Oh, thanks, okay. Peter. I would say this was an excellent presentation. I think underlying the emphasis of good bystander CPR, timely early response is key, because it's a chain. If you don't have that, everything else will fail. So very important to build the entire system.
I agree. I mean, it kind of reminds me of, you have to have a system that works like Disney World, right? You drive in, you go to the parking lot, the tram is right there, you get to everything. It works, right? We've only had, Tommaso, I believe, the folks in Minneapolis, I believe the folks in Albuquerque, New Mexico have done this. But to my knowledge, and maybe Ken or Mo can correct me if I'm wrong, but I don't think, are there any other centers doing pre-hospital ECMO CPR, ECPR in the United States today?
Not that I'm aware of. I know I wanted to do it back in 2014. I just couldn't get it through the regulatory stuff to get it done, because I really think this is a way to improve. No, it's difficult to pull off because you're not using physicians in the United States. But as you mentioned, there are a couple that have now solved the problem. I think that's definitely going to be a way to the future.
Mo, thanks, Ken. Mo, what do you think?
Yeah, I agree. I mean, I think we're actually trialing this in Portland, but it's not easy because the commitment 24/7 from the ECMO centers is the key. And that is where the current roadblock is. But you need to put the other pieces in place. But once that happens, then the next thing is the commitment. And I think what he also said was doing ECMO on a regular basis, not just for ECPR, but for other indications. That allows your system to be ready to go.
Yeah, that's very, very well said. We have actually a survivor in one of my systems, because our hospital system is a big ECMO center. And so we have a process where if we get a refractory VFib to that location, the ECMO team would be ready. So we have, I don't know if Randy Katz is on the line, but I think, my opinion for all the people on the call, that if you have an ECMO center and a resuscitation center like Ken and Carrie are working on, that's the low-hanging fruit, is to develop a process with that ECMO team, tell them we're going to have a pre-hospital alert, these are the criteria, we're going to bring them in, we're going to hand them over to you, and then they'll make the call, in the emergency department at that moment. I think that's the low-hanging fruit. Getting it out to EMS, I mean, that's a tough one, and I think that a lot of systems probably aren't going to go for that because of the cost and the amount of logistics and the cost and all that kind of thing. It's going to be very difficult. But Tommaso, let me give you the last word. First of all, I love your slides. You're a great presenter. give us the last word, and then we'll head over to Dr. Pepe's webinar. Take it away. Any last comments from you, Tommaso, before we go?
So I agree. I would like to thank you everyone for the comments, for the positive comments, and I think that the EMS community, cardiac arrest community, all agree with this concept. So I'm very happy to have found people that agree with this concept, that we have to work on this concept. So thank you very much.
I appreciate it. If it's okay, I'll share your email if some people want to reach out to you. Is that okay?
Yeah, fantastic.
Awesome.
Thank you very much.
Awesome. And next time I'm in Milan, I'll make sure to knock on your door and come visit. We'll have some coffee. And you're more than welcome to stay on. Let's see, Angus, are you there? Are you going to be able to switch us over to the Dr. Pepe's show?
Hey, yep, I'm here, Peter. Sorry,
Okay.
jumping on consult too. I will get you switched over in just 1 second.
Okay, awesome. So, Tommaso, we're going to go over to the kind of